some of you know this, some of you don't. We used to do two separate webinars. We had an intro and we had a mastering. And then we decided that we would just mash them together. And that's what these have become. Josh and I do these together. Sometimes I do them with Megan. Sometimes Josh does them with Megan. So tonight you've got Josh and myself. So instead of mastering advanced intraosseous anesthesia, we are actually calling it a mash up. So welcome tonight. Sit back. We hope you learned something and get some CE credits. Stay till the end to get some credits too. Ann Bynum, pediatric dentist. This is how you can reach me with my QR code. I went to Florida State. We are booty right now. I went to Iowa for dental school, went to San Antonio for peds. And I started a practice from scratch, and I've been doing it almost 30 years now, actually. And have learned a lot along the way, mostly through errors and trials. I'm married to Matt Bynum. He is a general dentist. We met in dental school. This is recent from bourbon and baby teeth. And then we also had our 30th dental class reunion back at Iowa a few weeks ago. I'm proud to say I have a beautiful family. We have 3 boys, Matthew, Luke, and John. Matthew is engaged to Maddie. Luke is engaged to Faith. And John will probably get engaged to Sal as soon as they finish college. They're both seniors this year. So my greatest accomplishments all on one slide.
These actually aren't her children. She just decided to find the best looking people she could in a magazine and just posted them.
I just put them up there. That's all.
Yeah, exactly.
Here's another beautiful person that I cropped in. This is Megan Kurowski. She is a KOL with NuSmile, and she also happens, luckily for me, to be my business partner. And she is truly a goat. I love working with her. For those of you who need help, she's usually one of the first ones that pops up on the Facebook group to help. She's got lots of great knowledge to share clinically with these devices. And she and I are definitely the ringmasters of the shit show at our practice. This is the show right here. These are the people that keep the train on the track. They're fun. It's like family. We always say we spend more time with these people than we do our own family. I also run the Tot Spot, which is the airway center that is run out of my practice, and we help lots of kids and lots of families that way as well. So I do have a few things going on at all times. I call it running from my problems, and I'm glad you can be here tonight while I do that on this webinar. I'm Holly Tree. My husband is Bynum Aesthetic, and then we have the Tot Spot. This is what our practice used to look like. We gave it a major facelift this year. We gave it a fresh painted coat, and we added 4,500 square feet onto the back of it.
Hey, that's me. So I will embarrass Ann for a minute here and tell you that I just had the opportunity to head out to their practice not so long ago to teach a hands-on course. And I tell you, one of the happiest staffs and well-run practices that I have ever been to, and I've been to quite a few in the last 20 plus years. So use both Ann and I as a resource. We always say, Chris and Aaron and Jordan, I'm sure they tell everybody that, our job as KOLs and NuSmile is much more important than just learning IO. We know all the products, but we're also here to help all of you guys. If you have questions on practice management, all those things, NuSmile really tries to be all encompassing for pediatric dentists. So please, if you have questions, if you need things, you reach out to us. Just super quick about me. I'm a 2nd generation pediatric dentist. I'm on the other coast in Livermore, California. So about 45 minutes east of San Francisco. And where Ann, centers a lot of her teaching on practice management and team building. I spend a lot of my time on fixing teeth. And so I have my own training center, BioClear Pediatric Training Center, and I lecture and teach all over the place. And I was just able to go to Mexico City for NuSmile, and man, those people know how to live life. Let me tell you, it was amazing. And we gave the same instruction to I think they have 35 residency programs in Mexico. So I was very glad to be there. So thanks. And next slide, super quick about me. Oh, nice. You put these in our East Coast Training Center. Yeah.
You'll see some surprises tonight, Josh.
Oh, I like that. So the Bynums have adopted me, and I'm going to just live in their house. And no, but you see their beautiful classroom there. They're in 10,000 square feet and 24 ops. And you see what we did is, we convert those operatories over to teaching centers, and we had an absolute great time. So if you go on my Facebook or Ann's, you'll see all the social media videos, and they're also teaching intraosseous anesthesia, many different places, like in their office. So I was very glad to be there, and we have 2 dates for next year.
Well, that was very cool too, because it wasn't just Josh's course that got taught. People got to see, and we have 4 units in the practice. So they all got to, people wanted to use the SleeperOne, they wanted to use the SOANs, and they used them on each other. So it was a really great opportunity to showcase them and let people, play with them who hadn't seen them yet in person.
And I got to watch Dr. Matt and his skills with the quick sleeper for the first time. So that was very cool.
Yes.
So we have a couple dates next year. We're starting, we have a new course that's ortho-pedo combo that, we'll put out online. So that is my contact information, Joshua at pediatricdds.com, or you can take a QR code. I try to be very reachable. If you reach out to me and I don't get back to you in 24 to 48 hours, please reach out to me again and say, hey, you're a jerk. You said you would call me back or write me back. I will get to you. If I'm traveling to speak or teach, it may take me a little bit, but I'll get back to you. So I think that's enough about me. Just some pictures of my office. And there's a mix of when we teach courses and just normal patient days. And let's take a poll.
All right, let's take a poll. All right, I'm going to launch this poll. 3 questions, really, really simple, everybody. If you can answer those, and we'll share the results. Should see that on your screen now. There's our first one. There we go. All right, looks like mostly SOAN users, with the other majority non-users. Exciting. Who is using these devices exclusively? Most do not own it. Few people are using it on all patients, only on patients until a certain age, a couple as well. And occasionally fall back to my traditional syringe is unfortunately the second common answer. What is your delivery method preference? Cruise or drive? Most of you said not sure, so that's good. We'll definitely cover that this evening, between the difference between cruise and drive. The people who are using it, looks like it's split, cruise and drive, about half and half.
Chris, I'm sorry I didn't catch. How many people on tonight do not have the unit?
57%.
Okay, good. So we'll get to both categories there. People that are don't have one yet, and then people that have one. That's great.
Yep. So 57% don't own one, and 43% own a SOAN. No SleeperOnes.
And I would encourage all of you who don't own one yet, definitely you may feel a little over your skis on this webinar tonight, because this does have a little bit of a mastering to it. So go back onto the NuSmile website. That's where all the past intro webinars live. And I encourage you to watch some of those, because that's where you'll really pick up more information about how the devices work just on a day-to-day basis.
And you can also come out for a hands-on course in November. We'll get into that in a little bit.
Yes. Okay, so back to our mashup. Tonight, we are also going to dazzle you with some practice pearls that Josh and I have thrown in here for the evening. Josh, see your initials up there?
Sure. Oh, yeah. Thank you. So I am getting in my older age with pediatric dentistry. So I graduated my residency in 2003. So I've started, actually, I remember meeting, because I was in Houston where NuSmile is based. So I've had the opportunity to see all of these products come to market. And as I look through the list, I use everything on here. One thing I do want to point out are the zirconia permanent crowns. I just got back from Mexico City lecturing on them. And anytime if I'm in a lecture on a subject, I get to dive into it more. And I tell you, the more and more that I use them and I see them, they are underused in pediatric dentistry. I think the one point I want to make here is, all the studies that have been shown with these crowns are that as long as you keep the glaze on them, you are not going to abrade opposing tooth structure. Be a little bit more careful with stainless steel crowns, but if you have an opposing natural tooth, like an opposing 6, they are not going to wear down. If you want the studies, I'll send them to you. And those preps are as easy as on primary teeth, and they're absolutely gorgeous. So if it's something, you're thinking about adding something else to your practice and you want some help with it, you have questions, please let me know. And if I don't have the answer, I'll kick you over to Paul Bond or one of these other amazing clinicians that place a lot of these, but it's definitely something to look at if you have not done so far.
So what is intraosseous anesthesia? First time I heard about it was at a bourbon and baby teeth event in 2023, and I wasn't even going to go into the lecture. That's a whole nother story, but I did go in, and I think that I missed this in dental school. Like I must have not gone into the lecture in dental school. I really didn't understand this. I don't think we did this technique in dental school, and I really had to go back and get in my head, what does this mean? What do these 2 big words mean? And it really means into bone inject. That's all it is. It's just 2 really long words that sound intimidating, and it's really all we're doing. It just means that we are bypassing the soft tissue and the skin and twiddling our thumbs, waiting for our patient to get numb. We're going straight into the bone, which is going to carry that anesthetic straight to the apex of the tooth and numb the tooth.
One important thing to know, and this is for those of you that haven't bought units and those of you that have one, is parents are, I find, always leery of new things. It's different, if Dr. Matt Bynum buys a super cool thing to put an implant, that for adult patients, is exciting and things are, progressive. In pediatric dentistry, I find we have to be a little careful with that, right? People don't want to have their 4-year-olds with you signing a new toy that, hasn't really been used quite a bit. What we need to understand is the idea of intraosseous delivery of local anesthesia is not new. These devices, although they may be new to the US, this was described in literature in 1906, right? And the key term here is analgesia is immediate and absolute. And I will tell you, I have only picked up a standard syringe maybe a handful of times when my SOAN or SleeperOne was not available. With a child or a teen under the age of 14 since I started this, right? And it's kind of been a contest in my office of how little I can use a standard syringe. But you need to know that this is not new. You're going to be safe. You're not, doing, I would be more concerned about using a new type of local anesthetic that just hit the market than the procedure that we're going to show you. So devices are new, but not the procedure itself. And, it's funny, all of us have so much technology that we've changed, right? I equate this to digital x-ray. I could not imagine going back to being in the dark room with the chemicals and opening up the little packets, right? And we have all this other technology, intraoral cameras, digital panos, cone beam, but things have not evolved, right? And if you look at that setup from the 1900s, it literally is pretty much what we use today, besides a needle that you have to manually sharpen. But now we have devices that will completely change the way you practice. When you introduce these to your parents, because mostly that's what you're doing, I like to call them digital pumps, right? It's just a simple way of mom, dad, caregiver, we're giving the same type of anesthesia that we did before, except now we're using a digital pump. And to make it, less painful and immediate to your child. It's just a good way of introducing that to your practice, to your, your team members, that this is just a digital pump. So what do they look like? There's 2 different versions. The business end is the same. So the types of needles you're going to use are exactly the same. The local anesthetic types you're going to use are exactly the same. One is corded and one's cordless. I have both, and I like the SleeperOne. I like the weight of it. I like that I can see the light all the way around. It really, at the end of the day, the analogy we were talking about this is, you can give a professional golfer an old set of golf clubs, they're going to do great with it, right? Once you understand the technique, you can switch between SOAN and SleeperOne, no problem. But if you're only going to buy one unit, then you're going to buy the SOAN. I do, and to to make sure everyone understands, Ann and I don't get any money from you guys buying these units. We don't get like a percent. We should work on that.
You
Jordan,
don't. You don't get any, Josh.
No,
you don't.
We don't get anything. So,
I don't.
Our
right. I don't
our motivation here is just only to elevate pediatric dentistry, and I will tell you that you don't want to have one of your team members drop one of these things, right? They're not inexpensive, and very quickly, most offices wind up buying several units. So if you have that availability, often NuSmile gives discounts buying more than one. There's enough of us using these now that that this is here to stay. And if you're going to buy a SOAN or a SleeperOne, you may want to think about buying two of these. I know it's a little bit expensive up front, but just something to think about. Okay, but technology is excellent for them both.
Anything else you want to say there?
No. Nope.
So what benefits do these devices provide to the patient? This is the big one right here, right? No one is chewing up their lips. You don't have to put a 4x4 gauze in a kid's mouth when they leave your practice anymore. Their lips are not numb at all, cheeks, anything. They can go back to school. They can go to McDonald's and, eat on their way. No one's going to the emergency room and drumming up some I'm allergic to anesthetic situation by some ER doc. So this is a huge benefit for our patients. And I immediately think of our special needs patients, right? They're the ones who really struggle with having a numb face. They can't understand it. It can last for over an hour. So just think how compassionate this is for those patients.
And can I say one quick thing about the lip numbness? I never realized how much the numb lip affected children until I started using these units. Because, most of using topical, using nitrous, and you give a block, most of us can get through that, get the patient through the block. But what I realized is how many times children, the behavior started to decrease when their lip was numb, right? And not having that numb lip and being able to tell parents, yep, send them back to school, you're good. That's worth its weight in gold right there. And I just find my cooperation level of my patients has increased dramatically.
So benefits to us as the doctors, one is visible right here on this slide. When you don't have to aspirate. You're not constantly, retracting a plunger, pushing on a plunger. That is a lot of wear and tear on our hands. I've been practicing almost 30 years, 10 ops a day, 4 days a week. Do the math. My hands have to go another, I don't know how many more years, but I don't want to tear them up doing this motion multiple times a day. And it's going to numb the patient immediately. So I find that a benefit to the patient and to the doctor. I don't have to leave the room. Now, let's say I've got 4 recalls I need to check. I can leave the room. Doesn't mean I have to start right away, but boy, if I want to get it done, let's say it is a special needs kid that's going to, is experiencing some anxiety. I can get it done right then. Let's say it's a little, a 2-year-old or something, trauma. I can get it done right away. I don't have to sit there and let that kid cry, for 5 or however many minutes until the numbness starts to take effect. And then also cross my fingers and hope that I did get them numb, because I'm literally injecting into a, balloon of a space, hoping that my anesthetic is going to travel where I want it to travel to.
Oh, this is one of the best things ever about local anesthesia. With IO, if you look there on the bottom, so this is the case that sold me on this, that I could not do this any other way. So this was a somewhat cooperative 8-year-old, but somewhat being the important word there. And normally, if I was going to take out NOPQ, that would have been multiple injections, right? Lingual and in the vestibule. And that kiddo, I gave 1 IO, half a carp with 1 to 200,000. Patient did not even flinch, and NOPQ out, right? Immediate, profound local anesthesia and no numb lip. So when we say pain-free, I would say my experience now is 9 out of 10 patients do not move, don't flinch, don't feel anything. Depending on your angulation, sometimes they will feel a little pressure. At first, when you're learning, if you don't angle things right, they may feel a little bit of a tiny pinch on that stage 1, but I will tell you now, I rarely have that at all. They may feel, again, pressure. We know that once you get into that cancellous bone, there's no nerve endings there, but they will feel some pressure. And that's why tonight, when we go into a little bit more detail, you want to make sure your settings are correct. You want to make sure that your pedal and your unit is set to give IO. I have not had one numb lip or tongue in my practice for the entire time that I've been using these units, which is now over, I don't know, at least way over a year and a half. And I literally have not had one. Not had one. I have not had, a child even afterwards feeling a little numbness in their lip. Just does not happen. I'm able to group appointments much more now, because what happens is if I have enough time, and let's say I'm going to treat R, S, and T, if that patient's cooperative and we've got enough time on the schedule, I will jump over and treat the contralateral side. Now, I never would have done that before. I was not a big fan of giving bilateral blocks. What you're going to see now, for those of you who are new, is the whole idea of a midline's gone. You do not have to worry about that anymore. You can treat that quadrant, and then you've got extra time, patient's cooperative. We've already talked about that in our huddle in the morning, and we're going to hop over and do the contralateral side without an issue. Half carp on one side, half carp on the other side. Patient leaves with zero numbness of their lip and tongue. Okay. You can start immediately. Anne made a good point. You don't have to. I don't want people to feel like you're under the gun, because they are, numb instantaneously. You can get up and do some checks and come back. I do that all the time. What it does is it gives you flexibility, right? You didn't have this before. If you're doing, I know in Anne's office, so well organized, they do a lot of same day treatment, and you are able to move around and not have to necessarily set right away what you're going to do. You can block the time and say, okay, great, we're going to, mom, dad, we're going to try to get this side done. If they're cooperative, maybe then we'll do the other side. You don't have to plan, at that out. You can just book the time, and what you get done, what you get done. I have found that my use of actually, the funny thing is I may wind up having to give up my conscious sedation license because I do such little of it now. In California, we have a minimum every 2 years, and it's actually a good problem to have. But the amount of oral or intranasal anesthesia or sedation that I'm doing has gone down to infinitesimally low, because I have 2 3-year-olds that I could give an IO injection on, no pain at all, and get anterior teeth done. I know I've seen it in Anne's office. They do it all the time, and in a very short order. And, the most important thing for me as far as patients go is I just don't have the crying. I don't have the amount of patients crying and parents crying. And then I never realized I knew how stressful it was to hear crying, but it takes a big toll on your staffs too. They're with you more than they are their families. And I want everybody's stress level to be low at the end of the day. And if I have a happy parent, life is good.
You want to talk about any of those other bullets down there?
No, we'll get to them. All right. So, why are we going to rethink this? And just kind of a summary. Number one is I don't want to be that person, that pediatric dentist that comes into the office as a parent and say, oh, my pediatric dentist was awful, everything pinched. We're the first in. That's a big deal. That's a big deal. If we were the first dentist that child's going to remember. And if I can set the stage for the beginning and I can tell parents, listen, most children don't even feel the injection. What I found secondarily that is I have a lot less parents helping to prep their children ahead of time. Well, you're going to feel a pinch, honey. It's not a big deal. You're going to get one shot. Don't you love when they all say that ahead of time? But I find parents don't really have to warn their child, because I tell them, honestly, 9 out of 10 times they don't even feel a thing whatsoever. We don't need to do supplemental injections, right? Every time we have to go into that tissue, there's always some trauma involved, right? And if I don't have to give a palatal ever again, if I don't have to give multiple injections in the quadra, that's great. When I do a block, typically I'm giving that block and then I'm giving, some supplemental local in the vestibule. It's really nice not having to do that. Control the patient movements. And Anne and I talk about this. Ideally, you're going to hold your patient to have them in Larie's circle of safety. But there's sometimes if the patient's doing okay and I'm doing okay, I'm just kind of sitting there and holding the unit while it's doing the work. And it's happened multiple times a day, and I'm talking to the parent, I'm talking to the child. And what I find is when our stress level is low, we project that to our parents, right? And when our stress level is high, we project that to our parents. They know if you're running behind schedule, right? And that child's having a tough time. So if I can control my own emotions and my staff emotions and the parents and the patients, that's a really good day. And again, I'm keeping everybody happy. So that's a very good thing. When we say there's no collateral numbness, I can honestly say, like I mentioned, I just haven't had it in my practice. The only time, let's talk about more for the advanced users. If you find that you're having collateral numbness, it's typically because you gave, number one, too much local in that first stage. For those of you new, you won't know what that means yet, but we'll teach you. Or you did not actually penetrate into the bone and you gave that bolus of local anesthetic in the vestibule itself. How do you test them? Your initial stage 1 should just be, and again, if you're new, you won't understand this yet, but your initial stage 1 should just blanch in that little papillary triangle. If you are seeing that vestibule getting blanched as well, you know that you're delivering local in the place that you don't want it. If you do everything correct, you should not have a numb lip. You should not have a numb tongue. All right. There's this cool thing that they come with, and it's called an instruction guide. Right. Read the manual. Thank you. Ann and I, or Jordan, or Aaron, or Chris will help you, but they may be less snarky than I am. I will. The first thing I will say is, did you do the onboarding yourself, and did you read the manual? I won't be that snarky, but we need to remember these are devices that we're delivering drugs to children. Okay? And we need to take it seriously, right? Although these are easy to use and the instructions are easy to follow, this is a drug delivery device and we need to take that seriously. And so what I encourage everyone to do is, if you've already been using it, get the manual out and read it. It's not very long. They have lots of, like for kindergartners, they have lots of pictures and diagrams. And if the onboarding, if you delegated that to a team member, I would suggest going through and watching the videos. I find that if you do those things, you're going to have far few questions. And you can download them there.
All right. First pearl of the night is my pearl. This is what we do in our practice. We onboard lots of people. Like we just added on to the building 4,000 square feet. So now I have to fill that with team members that can take care of more patients. So this is something that my leadership team actually came up with. And we have 30, 60, 90 training checklists, and the assistants or the admin people who are training the new hires. This is how we give feedback now. So it's, are they in trouble? Are they mayday? Are they, they're getting it, but they're not there yet, or have they mastered it? And then when that assistant gets passed off to the next training person who's going to be training them, that person can look and go, oh, these are the things she's still struggling with or he's struggling with, and I can help them. So if you want to get these from me, you will have to reach out to me to get them.
Can I just mention one quick thing there? I always like to hear you talking. One of the pearls that I picked up from Ann and some other people is they started, as they're onboarding people, taking a phone out and actually recording. This is how we click through the schedule. This is how, and they just kept a library of all those things. And then that way they're not having to make things new when they have a new team member on. There may be corresponding videos with that. So just something to think about along with that.
All right, Josh, be prepared to tell me how it works.
Do it. Okay. Many years ago, I was sent a X-tip, right? And the X-tip, you drilled through the bone and then you took the thing out and you put the needle in. And I distinctly remember every time I would use the X-tip and create the little lumen, when I went to inject, the patients would groan. And what they were feeling was pressure. The important thing that we need to remember for all local anesthetics is we need to give them slowly. We should be delivering, doesn't matter what unit you're using or manually, we should be giving about 1 milliliter a minute. Now, how often do all of us do that? Probably not. For a painless injection, the important thing here is you've got to use an electronic device. Even if you were to, I read a while ago, someone said they just took the needle and a manual syringe and went through the bone. Yes, you can do that. You can take a short tip needle and push through, but I promise you will not be painless. And the other important aspect here is if you are trying to manually deliver that local anesthetic intraosseously, you're going to have a large diffusion because the pressure is so high. You've got to give this drop by drop, and that is impossible for anyone on this webinar tonight to do that. So it has to be an electronic device. When we have an electronic control over the local anesthetic, there's a few things that happen. Number one, you're going to be safe. I promise you, these units are measuring the pressure constantly, hundreds and hundreds and hundreds of times a minute. It will not let you get in trouble. If it notices a blockage, if it notices the rate is too high and it's sensing back pressure, it'll shut you off. It'll either warn you, and then it gets to a point where it's too high, it'll automatically shut you off. So there are more safety controls with these units than you ever think that would be needed, but they are. And the important thing is, as we give this drop by drop, we need to keep that bolus of local anesthetic coalesced in one area. If you give too much of a amount of local anesthetic or you give too high of a pressure, what will happen is you will have spread to diffuse through the bone, and you'll just get a lot of teeth kind of numb instead of the teeth that you need to have numb, very profound. So you have to do this with electronic device. The other important aspect here is, sometimes we get asked, well, what about a woodpecker or a whatever thing you buy from eBay for $50 to try to give local anesthetic? You need to have a device that is FDA cleared to give intraosseous local anesthesia. And from what I understand, and I'm about 100% sure, these are the only devices that have clearance for giving local anesthetic, especially to children. And it's giving that drop by drop local that is allowing that bolus of anesthetic to just stay where it needs to be. So let's talk about diffusion here and how this works, okay? Of course, when you give a block, let's think about a lower block, right? Think about it like if you were to want to numb your finger, why would you numb at the elbow to give a block? You can do that, right? You can do a finger block and numb the entire hand. That's what's happening when you give a block in the lower. It makes absolutely no sense. And until I learned all these experiences, that was just the way we do things. So on the lower arch, we're not starting at, the base of the IA, right? We're giving that local anesthetic right next to the tooth. There's a few rules you can follow as far as how many teeth you're going to have profoundly numb in that quadrant. We need to remember that the upper arch, that's a very smooth transition, thank you. The upper arch, in general, you're going to have 2 teeth distal and 2 teeth mesial that become profoundly anesthetized. You will get some bonus teeth, right? We don't want to guarantee you that, but I will tell you that depending on your positioning and how much volume you give, that you will sometimes get more than these 2 teeth distal and 2 teeth mesial. There's omnidirectional flow of local anesthetic and a blood flow in the maxilla. The mandible is a different story. The mandible has a bias of flow from the distal to the mesial. So you will get 1 tooth distal profoundly numb, and we're talking about where your injection site is, and then mesial, it's 2. So the upper, it's 2 and 2, and on the lower, it's 1 distal and 2 mesial. There's one caveat here, okay, and this is important to understand, is these devices really are truly designed for primary mixed dentition. Can you use them in adult dentition? Yes, absolutely you can. We use, vast majority of the time, the 9mm needle. Okay. So a 9mm needle for a fully adult dentition, let's say 13 or 14 above, these rules change a little bit because that needle is not going very deep. I can guarantee you're going to have 1 tooth mesial, 1 tooth distal profoundly numb on both arches. Anything more than that is a bonus. So I don't want you to think you can use a 9mm needle for your adult dentition and always have 2 and 2. Guaranteed you're going to have 1 and 1, usually more than that, but that's just one caveat I want people to understand. Again, for older patients, fully adult dentition. All right. So when we talk about stages, for those of you that, and is this supposed to be me or is it supposed to be you? It's you.
You can keep going. You roll on this. I'll take the
Okay. Hey, thanks. I like talking. All right. So when we talk about the stages, some people have already asked any questions about the stages. There's 3 stages to this injection. The first stage is we are numbing the soft tissue, right? If you're going to penetrate through bone, you better make sure that everything superficial to that bone is numb. So the first stage, you think about a triangle. We talk about the papillary triangle. It's the papilla between the two teeth where you're anesthetizing. That's got to be profoundly numb first. Then, and we're going to come in horizontally, you'll see that. Then stage 2 is the MBP, the manual bone penetration. We are using a needle that is so sharp and a patient population that has thin cortical plates that we're actually physically pushing that needle through the bone. Okay? Then the third stage is the actual delivery of the anesthetic itself. This whole injection cycle is about 2 to 2.5 minutes. That may seem long to you, but I guarantee you, if you look at any textbook, that's how long you're supposed to be doing to give, a pain-free or painless injection. So it's 1, 2, 3. Soft tissue initially, superficial to the periosteum, then penetrate through the periosteum, and then delivery of the anesthetic itself.
So let's talk about that stage 1. You're going to have this pedal that's going to drive your device, whether you have the SOAN or the SleeperOne. This is what your pedals they're very similar to one another. And when we're going to deliver that stage 1, we're stepping on the middle part of the pedal, which I just think of it as like it's small, like the papilla. So I'm telling myself my foot goes on that part. The other thing that I didn't know till I was like 6 months deep into owning these devices, when you lay your foot on there, if your foot is touching the middle pedal and the outer pedal, it's always going to default to the middle pedal. So you're never going to be wrong if your whole 10.5 foot shoe or whatever it is, I'm not 10.5, I'm 7.5, it's always going to hit that middle. It'll always default to the middle, to the tiny pedal. The other thing you need to know is that on these needles, these proprietary needles are called Epitech needles. Josh was explaining how sharp they are, and they are like a scalpel blade, and that's what helps make those injections so pain-free. On these needles, there's a letter D, and it's very important that that D is always facing out. It needs to be facing facial or buccal to the patient when you're given stage 1 of the injection. Stage 2 doesn't matter. Stage 1 matters because we want that scalpel to lean into that tissue and not cause trauma. We want it to basically like just lay into the tissue like butter almost. So you want to always make sure that your D, I like to have my D, I put this picture here because I want to have the D lined up with the lights, because the lights on the SOAN are only on one side. So I want to see the D and I want to see the lights at the same time. So if your assistant or yourself screws the needle on and the D's not in line, just back twist it until it's in line.
All right. When we discuss the papillary triangle, I want everyone to understand that's the triangle that we're talking about. The goal there is to only have blanching in that triangle. As I mentioned previously, if we can go to the next slide, actually, and that's great. The triangle is just that portion. If you were to take the free gingival margin of S and T there and draw a line, that's the base of your triangle. The tip of your triangle is the most incisal portion of your. The stage 1, and Anne already alluded to this, when she talked about laying the needle down, that's probably one of the best things that I learned, one of the many from Dr. Prin, is that the needle is so sharp that literally all you need to do is think about just flexing the needle against the tissue and it will penetrate. I find if I push, then I'm going to push the needle into a portion I don't want. This is a very important point here, okay, you guys? If you were to take that papillary triangle and you split it in half, the goal is to deposit that bolus of local anesthetic right in the middle of that triangle, correct? If you were to start that needle right at the middle, what'll happen is you're going to push that needle and the fluid, in this case, distally. Well, what do we know that's distal is the PDL. What has a lot of nerves in it is the PDL. So if you want to have an unhappy patient, you're going to take that needle and start right in the middle of that triangle and then push distally. So in summary, I want you to go 1 to 2 millimeters, in this case, mesial of the midline, and just think about taking that D that's facing out and just literally pressing it against the tissue. It'll go right through. The whole goal is, again, just blanching in that triangle itself.
So I'm going to show a couple videos here of what this should look like. And the thing is, you've got to master phase 1 if you're going to have success in phase 2, because you're going to lose the patient in phase 2 if you don't get this right. This is a great video because I think a lot of times we can, sense a patient's pain level by what their eyes are telling us. This kid could care less. I don't have the volume up because there's a lot of back chatter going on, but she is singing the song that's playing on Alexa while she's getting her mouth numbed right now.
One quick point here. For video, sometimes we don't hold or position things exactly how we would if this was in the mouth. That first stage, typically, we highly recommend that you have a finger actually on the tissue, on the tooth, supporting things. We just didn't in that video because if we had our holding everything how it should be perfectly, you couldn't see.
You can't see it.
So typically, if you want to play that again, Anna, because it's a point there is, if this was IRL, as the kids say, then there would be one of those fingers that is resting on the teeth themselves, okay? But you see she doesn't react. It's really nice. But if she did react, you want to have a more stable base than just resting on the lip. The other point is I think I learned this from seeing one of Anne's videos, is tapping with that suction or tapping on the outside of the face. That is another great distraction. And I think sometimes we get so focused on just doing this right, we forget that there's a child on the other end here. So I would definitely make a note of tapping because it helps.
All right, here's a couple other phase 1s. This is actually me forgetting to make the D face out before I start the video. Okay, there we go. And you can see these 9 millimeters, they're very flexible. That needle, you can see it bending in the video. And that is normal. That is totally okay. Here's another one. This is Dr. Nash in our practice.
Who happens to be the nicest, smiliest human I think I've ever met.
He is hilarious.
And can I make one more point here?
Yeah.
For those of you, because we've had some questions even before the webinar, can you go back one stage, one slide? I have gotten some questions from a few of you about, well, why can't we just give the first stage and the second stage in the same angulation, okay? And I remember asking Dr. Prin this question early on. If you notice that first video, they're not going in at the horizontal angulation that we typically teach, okay? You can do this. Play that video for me one more time, will you please, Anne?
This page or the page before?
That one, you got it. So if you notice, the angulation they're coming in is very similar on stage 1 as it would be for stage 2. The reason why I want you to be careful doing it this way is Anne's an expert. Okay, she's done this way more times than I have, and she is comfortable giving that stage 1 and not oopsing to the periosteum. If you give the initial injection horizontal, you're less likely to actually touch the periosteum. It's a little safer. This is more, I would call, this is the varsity move here. You can give stage 1 like this, but I do want you to be careful. Again, she would in the mouth, she would have usually a finger rest on the teeth. Again, this is for video, but I do want you to be a little cautious. If you look at the way Dr. Nash gave, right, he's coming in horizontally to the papilla. I'd like you to start that way. If you feel comfortable and you get an idea of depth, you can do it the left way, but the right way is going to be a little safer as far as not having an oops and touching the periosteum before you.
And we do teach it that way. We have 5 doctors in our practice, right, and we teach it the way Josh is saying. All right. Stage 2, we're going to use the outer part of this foot pedal, and these are going to be some videos of what those injections look like. This is Dr. Nash, who you saw earlier. We can, source him out with his black gloves there. And this is a pro tip here. You're going to twist.
Oh, that's great.
That helps you make sure you're in. Then you can do some tug back, make sure you're in the bone.
That's a great example.
Yep. And just showing you with those lights. Josh has talked about pressure a little bit. I'm going to talk about that in depth here in a minute. And this is stage 2 on. This is actually my husband's assistant's kid. And same thing. I'm going to go in and I'm checking for tug back, making sure I wasn't in. So I'm going to twist. Now I like it better. It's not coming back at me when I give it a tug. And I'm ready to inject.
Great.
I just put this x-ray up there because that is one thing that's very important. We talk about it in the intro webinars a lot of great examples of it. You have to have bone. It's not an intraosseous injection without something osseous. So you really got to be checking your x-rays and making sure that you are injecting into an area that has a good source of bone. All right, pearl number 2. Mine also. This is merch. This is a Jeanette McLean suggestion, and it's one of the favorite things that our new patients love. It's these magnets that go on the fridge. We take a picture of the kids. I just had somebody order them that saw me give this pearl in the webinar, and he ordered them for his office, and I can't remember who it was or what they look like, but they came out so cool. So I just think that's a great little, when you're trying to stand out and separate yourself from the competition, this is a great suggestion, just having some really cool merch, something that's different. So teach me about the colored and the blinking lights. Josh, why don't you take these quickly?
Oh, okay. So with this SleeperOne, the important thing here is, it can be on different modes. Just worry about, it's supposed to be B for blue, okay? B for bone. We need to make sure that before you give that injection, you've got it on the right setting.
So blue, the light will be blinking blue if you're in the right setting for intraosseous.
And then pink is for PDL. So I do use this, let's say as a backup, you couldn't get bone penetration and you're going to give bolus in the vestibule, you'd have it on pink. The other thing is for over-retained teeth, I don't bother giving IO. It's really not necessary. I will just put it in pink and give soft tissue or PDL. And then if you're going to give a block, which I don't think I've ever done with one of these, you'd have it on orange. And orange is the only color that will allow aspirations.
So the big takeaway from this is, even if you're not doing intraosseous, you still don't have to use your traditional syringe. You can do every other type of injection on the planet with these devices. So for the SOAN, very similar. This first light blinks for you, or these lights blink for you. Blue is for bone. That's when you want to give intraosseous. Pink or purple is for infiltration. So let's talk about these lights. They're gonna go up when it starts to pressurize. When you've got one little blinking light, that means you're go for launch. If that light is not blinking, you are not delivering anesthetic. So you got to really make sure your foot pedal, your eyes, and your device are all doing the right thing. If you got 2 blinking lights, I'm still go for launch. That tells me everything is still going well. If I start to see 3 blinking lights, I'm starting to pay attention. That means pressure is building up for some reason, and now I have to think through what could be going on. And Josh said this earlier, if it gets to 4 blinking lights and I don't do something, or the device doesn't something to make a change to deal with this pressure, the device is going to shut itself off because it's not going to let you do something that could be detrimental or harmful to the patient. So let's think about this. What could cause the device, why is it recognizing the pressure? Well, it could be that you have the needle pushed just right up against that bone, and there's no way for any anesthetic to even get out of it. You could have just butted up right up on it. The other thing is you could have picked up and carried a piece of bony spicule as you're trying to, twist it in there, and now you've got this bony spicule that is stuck in the lumen of the needle. It could be that the needle's bent, and now you've got, it's occluded that way on itself. And it can also be that the bone just isn't porous enough to take the anesthetic at the cadence that the device is delivering at. So these would be like the top 4 things I would say are going to give you this pressure reading. And then what can you try to come out of that, right? First thing is to be patient. Just give the device time. It is a very smart computer, and it knows how to adjust for the pressure. So give it time to try to adjust itself and see if those lights will go down on their own before you bail. Doesn't happen, you may need to back the needle off the bone a little bit. Don't take it all the way out, just back it up a little bit and see if your lights and your pressure starts to decrease. Third thing I'd recommend trying is removing the needle and repositioning, going back into the same area, but maybe at a little different angle. Next thing you can do is replace the needle. Just have a reset and replace the needle on there. What we want you not to try to do is to start by taking your foot off the pedal. Because every time you take your foot off the pedal, the device has to start all over again and reset itself and bring that cadence back up. And so now your 2 or 2.5 minute injection that Josh was talking about is now turning into a 4-minute injection because the device has to start itself over. So these are just some ways to dig yourself out when you're dealing with pressure.
Beautiful. One of my favorite things to talk about. Okay. So for topical, most of you will be babies and use topical at first. And I did for the first couple days. And then right after I think I got my device, I had an old composite needing to be replaced. And I tell you, the worst thing about that entire appointment was the topical that got in the back of my throat. As a novice user, you may feel like you need topical. I promise you, you can be highly successful and give a painless injection without it. You know, the less stuff I have to put in the mouth, the less caustic things I need to put in the mouth. You know, I'm blinking weird colors. We'll have to change that. You can get tissue burns with, depending on if it's one of the compounded topicals. So I really try. That's okay. My video, you can still hear me. Yeah. So I just find I do not need it. And then it's up to you on, you know, as you continue, if you need it or not. The only time I use it now, if I have very inflamed or infected tissue that I'm worried about, you know, that's just, it is has a hyper amount of nerve endings, then I may put a little topical there, but very few and far between. And so which local anesthetic do we use? You can use lidocaine if you want. People ask that. I mean, it doesn't matter, you know, specifically the device on what anesthetic that you use, although I will tell you that pretty much all of us are using articaine. So why do we use articaine? You know, we know that the structures, it's kind of a lidocaine-ish drug, right? And it has that amide group and theophylline ring. And what it does is it allows faster penetration through soluble tissues and lipid tissues, but it also hydrolyzes in the plasma, which means it's going to get broken down earlier, right? The other important thing here is that, you know, we want this elimination time to be quick, and I want to have as much of elimination in the blood as possible. We're still going to follow the same rules as far as the amounts, right? So that's what 7 mg per kg for, you know, for our patients. But there's too many good things with articaine to use it versus to use lidocaine. Can you? Fine. But the preference for almost all of us is to use articaine. So articaine comes as probably next. We can go to the next slide. Yep. So when do we make the decision? Okay. So don't look at the slide. Let's just think about this. Okay. Well, you can look at the slide if you want. We're using 4% articaine in the US. Okay. In the US, it comes at 1 to 200,000 and 1 to 100,000. If you are viewing this outside of the US, which I guess is posted online, that's sold in 1 to 50, we don't use that. So what's the decision tree in my office? Okay. Very simple. Vast majority of the time, I'm using 1 to 200,000. And we're talking about, this is the epinephrine concentration. My rule is if I have a hot tooth, a highly infected tooth, or I really need to maximize the amount of working time, I'm going to use 1 to 100,000. Doesn't happen very often. Vast majority of the time, I'm using 1 to 200. One of the nice things is because one is Septicane labeled and one is Articaine, the cartridges look different. There's a different color on them. But vast majority of the time, I would just, if you're going to pick one in your office, just pick 1 to 200,000. For teens, please make sure that I would use 1 to 200,000 all the time. Okay, because we're delivering more intraseptal anesthetic, we're giving it mostly just in the edge of that bone. You don't want to use 1 to 100,000 there. You have the possibility of having some ischemia of tissue. Make your life easy. Vast majority of the time, buy 1 to 200,000 and use it. If
And I would
you
just,
find,
can I say something
please,
else?
please.
If you're looking at this and you're like, oh, but I've got more than 30 minutes of work to do, give a second injection. If you think it's starting to wear off, just give another injection.
And if you're worried about your patient having, some pain afterwards, which they always did, it's just these wear off a little faster, so you may have it as they're checking out. You can give a couple drops at the end of the appointment. They're not going to feel it, and that just tops them off and send them home.
So one thing we hear is, why does it go so slow? And like we were saying, it really is supposed to go slow, and then it wouldn't be uncomfortable doing a traditional injection, but it really is not as slow as you think. Josh said, 1 mil per minute, so basically 2 minutes to get the job done, but we're not even giving a mil, right? I mean, if I'm doing 2 class 2s, I'm giving a quarter carpule. If I'm doing an extraction, I'm probably giving a half, pulping a crown or a hot tooth, probably 3/4. So let's just watch this. This is Dr. Megan. This is the x-ray on her patient. She's going to give stage 1, and she is resting on the tooth there. You can see that. Now she's given stage 2. Kid does not care. Fast forward here a little bit. She did a filling on a tooth, curing it. I don't have to talk you through the steps. You know them. Polished. Now we got to get a tooth out of there. Two teeth out of there.
That was actually in real time. She's that fast.
No, it's not. But the cool part is that entire visit was 7.5 minutes from start to finish. We schedule 30-minute appointments. I could realistically put 2 more patients in that room if I wanted. And this is what the sockets look like after this. They don't bleed. I mean, obviously, if the kid's going buck wild, they may bleed a little, but a calm patient, this is what you get. You get nice dry sockets, which is another benefit. This was Dr. Nash seeing this patient, and this was his first time extracting a permanent tooth using the device. So he was a little cautious, and he decided to numb on both sides of the tooth because he wanted to make sure the patient was numb. Fast forward. Again, never had to leave the room. Tooth is out. Less than 7 minutes. Beat Dr. Megan by about 30 seconds. This is where it's very compassionate, right? Like, this sucks, right? We hate this. A lot of times these are our trauma patients, but this is a kid that's experiencing some discomfort. So Megan's going to get in there and get it done very quickly. Again, that's the worst part, right? Is when you sit the kid up and let them sit there with their parent or whatever while you're waiting for them to numb up, and then you got to lay them back down, and they're like, oh my God, do I have to do it again?
as you're learning to talk to parents, please make sure you remind them about the instantaneous effect of the
Right,
local.
right.
I had one instance when I first started where one half of the mouth I had a standard syringe, and then the other half I had my SleeperOne or SOAN was one of them, and I gave my IO injection. I went to get rolling, and the mom jumped out of the chair. Wait! Aren't you going to wait for them to get numb? And it was when I was first learning and didn't have my whole shtick in place. But please remind them they are going to be numb instant.
But that's a 2-minute visit for that little kid. And that just, that reduces the anxiety for that parent as well.
Oh, one of my favorite. Okay. Angulation. Barry, you're out there. This is for you. So we often get asked about, well, if you're right-handed, what about the left side? Okay. So there's 2 things you can do. Number one, you can turn your patient, right? We always want the doctor to be the comfortable one. So you can have your patient turn their head all the way over if you need to get access to the left-hand side. Okay. Number one. Number 2, don't forget, you can put your isolight in first and then give your injection. That's a great way to do it. You've got perfect lighting, you've got a nice dry field, and you're not going to be worried about having dribbling local anesthetic in the back of their throat. Thanks to Eric Hans, who told me this early on, is you can absolutely, if you need to numb for I&J there or IJ14, you can do the same exact procedure, but do it on the palate. I wrote here, don't be a baby, because I was a little worried the first time I did this, and then it's absolutely fine. They're going to feel the same, painless injection. And I find it's actually a little easier on the palate. There's only 2 roots there. Someone has already asked, we can cover one of the questions. They said, well, what if you don't have good bone in the area where you need to inject? So if you have an abscess on I&J, this is a great thing to do. Just turn them slightly and palpal axis. Everything's exactly the same. I promise you, it's going to be the exact same injection, and you will not have an issue with pain, more than you would in any other place in the mouth. And don't be a baby. All right. So Paul Bond is the master of these pictures and taking photos at angulations. So great photo series here. Okay, again, Barry, if you're out there, you already asked a question, I think you're on. So what do you do about left-hand side? You can turn your patient if need be, or palatal is a great approach. So there was a, remember, we're going to check our x-ray first, right? And most of the time we know that parielis is going to be there on the buccal. So if you're trying to inject in an area where you have disorganized bone, where the soft tissues marsupialize that area, you're not going to get a true IO. Give it on the lingual. Okay, same exact rules. He's got, do you see his finger, his supporting hand there? That's what you want to see. Resting on the bone, having a good fulcrum. The other thing that I want you to think about, it's not just for this, but for any of your patients. The way I visualize it is, think about your SOAN or SleeperOne is weighing going from 0 to 1,000 pounds. So you want to have that angulation perfect when you get to the bone. And then instead of torquing your hand, just straight push, straight down like it's heavy, let it drop into the bone and you'll push through every time. It's the same thing like if you played tennis, and a coach used to say, well, think about you're hitting 10 balls in a row. So you're not, just poking, you're pushing. So constant pressure all the way through. And Dr. Nash had some great videos I hope you guys saw where he was just slight rotation that will also help you get through the bone. And don't forget to change needles if you need to. Okay, again, palatal approach. Just really quickly here. Now, this is an example of giving stage 1 vertically, right? Be a little bit more cautious here. What I tend to do, and this is more of an advanced trick, but I will tend to enter the soft tissue. And while I am while I enter it and while I have my foot on the pedal, I will slowly advance it forward. And that way I don't accidentally have an oopsie and bump into the periosteum, because you'll have an unhappy patient. Once you've got good stage 1, then you can just continue with your stage 2 all in the same angulation, but just be a little bit more cautious here. Thank you, Paul.
All right, let's talk about hypoplastic teeth, because if there was if there was no other reason to buy this device, I would buy it just for hypoplastic teeth because they stress me out. I don't know if I've got them numb. Don't give me a hypoplastic tooth on a redhead. That's a whole disaster in itself. So hypoplastic teeth used to terrify me. Now, if I go in, it says 19 occlusal, I'm not even worried about it because I know I'll get it numb. But here's an example of a hypoplastic premolar that we're going to try to salvage in our practice. And this is Dr. Megan going to work that miracle. Again, speeding things up for you. Stage
So
one.
I can, I treat a lot of hypoplastic teeth like this in my practice, and I can tell you, I'm at 100% for profound local, and I was batting about 60% with blocks.
So that's a great way to help those patients that feel, I mean, you can't even hardly do sealants on those kids because they feel so much discomfort with, cold air. Pearl number 3, Josh.
We're getting a little tight on time. Do you want to skip by this one or no?
Yeah, basically just pay attention to how much time it takes you to do something. You buy these devices and your a 40-minute op is now down to a 7 to 10-minute op at certain times. So the difference in drive and cruise mode on the SOAN, that's the SleeperOne does not have that, but the SOAN does. And it's just exactly like it says. Drive mode is like your rheostat for your handpiece. It's like a car. You are in drive on your car, you push on the pedal, the device works, it delivers anesthetic. If you want to be in cruise mode, you can take your foot off the pedal, just like tap it, and that puts it into cruise mode and to deliver the anesthetic. The issue can be is if you forget that you're in cruise mode and you set the device down on the back counter, then when you go to take it all apart, the anesthetic has just continued to deliver on the back counter, just sitting there waiting for you. We have 5 doctors. We have 4 rooms. These devices switch often between drive and cruise, lots of hands touching them. And I'm at the point now where it doesn't matter to me which mode they're in. I just have to know what I'm doing before I start.
All right. I alluded to this earlier. I would highly suggest purchasing these from NuSmile. So what I appreciated when NuSmile, this was, I don't know, maybe a year ago, they came to a lot of us that are using the units and said, hey guys, let's come up with this together. And so this wasn't just somebody in the marketing department writing the copy. This was a lot of the KOLs that helping write this. A lot of us, when you first get a device, you're excited and Mom, Dad, here's this new thing. I don't necessarily like new things for kids, right? You don't want to experiment. So what I tell them is, this is something we're using in our office. It's basically a digital pump. I'm using the same numbing medications that I always have. It's just now I'm able to give that medication right next to the tooth painlessly, and they're going to be numb almost instantaneously. I don't tell them, let me back up. If I know I've got to step out of the room, I don't necessarily include the instantaneous part. So that's just a little thing you may want to think about. Because if you need to give that and go do some checks, you may want to leave that one out. But they can eat and drink right away, and you're not going to be worried about numbness after.
So in our practice, we don't have parents in the room. They stand at a window and watch, or they stand outside and vape or sit in the reception room or whatever, but they don't come in the room with their kid. So we have these hanging on the windows if they do feel like they want to lurch out and stand at the window and watch. And it tells them exactly the benefits of using these devices.
And do you want to go back to that for 1 second and let people take a photo or screen capture of that? Because I think
it's for sure.
Excellent. Thank you.
And we're moving on. All right. So some things that we get feedback on are that the patients are experiencing discomfort, and that can be any myriad of reasons why that's happening. We're just going to focus in on a few that could be the culprit. Josh kind of said it earlier, the patient is not numb as long. So by the time maybe you did back-to-back siblings, and by the time you finish the second sibling, the first sibling's mouth is waking up and their mouth is sore from the dentistry that you just did. You did a pulp and a crown and an extraction, and they're sore. So they are feeling the discomfort sooner in your presence. So then you get in your head about it and you're like, oh my God, these devices made the kid hurt. Probably not the case. Multiple stabs. This is you learning the device, right? You're going in and out and in and out, and you're twisting and turning, and you didn't get it, and you had to change the needle, and it broke, and this and that and the other. So that can also make patients a little bit more sore and tender. So give yourself some grace and don't automatically go to, these devices don't work, I'm hurting people.
And you made one important point, though, and I don't want people to forget this. If you have to think twice, change the needle. Okay, if you're going to go to a second quadrant, change the needle. My rule is once in bone and then the needle gets changed. It's 27 cents. You're going to be okay. But Ann is exactly right. If you keep on going in and out with a needle that does dull after the first use, it's not going to be sufficient. You're going to have more possible pain with it. Change the needle out.
So right here, over delivering in stage 1, this is what it can look like. It can look ischemic. And it may, this probably happens more times than you know with your patients. But not every patient's a weenie calling back saying, oh, I got this thing back here. Parents aren't looking back in the back of their kid's mouth. So I think every once in a while when it's brought to our attention, we think, oh my God, this is happening all the time. It may be happening some of the time, but it's not a deal breaker for using these devices. And the other thing it can hurt, and Josh said this, you're in the PDL, bro. You need to back up. You need to go back to your anatomy and figure out what you're doing, because if you get a reaction from a patient that is, their eyes are blinking and they're in a lot of discomfort, there's a very high chance that you're in the PDL at that point.
Oh, okay. This is my favorite. Ann's sick of me talking about this. I do this mantra for every single injection. Okay, and there's distinct reasons why that I do it this way. I'll give you an example because this happened to me a day or two ago, where I went to give stage 1. The needle was in. I thought I was doing great. Hey, I'm a KOL. I know what I'm doing. And I realized it wasn't on, right? So first thing is, if you have a SOAN, I'm going to come into the room and I'm going to look, is the unit on? It does have options to change the standby time. But the default, and this is a question someone I think asked earlier, is that you can give 30 full carps on a full charge, okay? If you leave the standby time for 10 minutes. So sometimes team members won't remember to turn it on, so you pick it up, make sure it's on. So that's the first P, which is power. The second is the plan. Review the radiograph, especially, we want to see is just like you would for caries or pathology, right? I want to see, is there good bone in the area? Where's my best injection site? I will look to make sure that the correct anesthetic is in, right? Especially if it's new in your practice, they may have put in 1 to 200, 1 to 100,000. I want to have the suction going. One other hint here on planning, if your patient is super hypersensitive to tastes, spiffies, which are just, xylitol wipes that we use for babies, I have those in all the operatories. They're grape, they're apple, they have different flavors. That's a great way if you're having a kiddo that's unhappy with taste, having just ready to grow, they open it up like a KFC wet nap, and then you can at least wipe the tongue, okay? And then review with parent. I love Ann's. I hope everybody, makes something like that at their own. Some people I've seen have that on a card, and then they have on the back some marketing material inside for your office, hint, hint. So there's different ways to do this, okay? So power and plan. Then, and this is all before I give my injection, pedal. I want you to remember with the SOAN, that pedal needs to talk to the actual unit. These pedals are not battery operated, okay? And the signal that it sends is wireless. Think about what your chair is made out of. It is metal and wood and steel and electronics. And although it sends a strong signal, if your pedal is completely under the chair, often your SOAN will not communicate. I don't have that problem as much with SleeperOne, or really at all with SleeperOne, because the head unit is in a different location. But I will, if I have to think twice, I'll just step on it for a second and make sure that it's responding, okay? The last thing I want to do is give stage 1 and realize, where's the clicky? It's not there. Okay? So is the pedal in the correct location? And I will step on it. And then my positioning, is my pedal correct? Is my patient in the correct position? And my foot. So power plan, pedal, and position. I do it every single time in my head.
All right, pearl number 4. This is my pearl. I don't know if you saw these, Josh, but I love these. I got this on Amazon. We have this in every single room, and it's just all right there. We've got our cartridges that our containers that hold the anesthetic carpule. We've got the anesthetic, and we've got the Evitech needles right there, all at our disposal, right behind us. Because we used to keep all that in a drawer, but because sometimes you are changing out needles, I don't want my assistant like reaching into drawers with gloves and everything. Like, we have it right here, and we have a pair of tongs that you can reach right in, and you can grab a new needle if you need it. And that's the QR
What's
code.
the purple there on the?
That's a QR code. You can get them on Amazon.
No, I'm sorry, on the cartridge holder itself.
Oh, that is because we have the Quick Sleeper and we have the SOAN, and the cartridges are different sizes. So that's how we let our sterilization ladies know that is the carpule that goes with the Quick Sleeper. With the SleeperOne. I don't know what I'm saying. Yes, with a different device.
All right. What are some key tips to help me switch to electronic anesthesia? Number 1 is money. These devices are not free, okay? But I will tell you, they pay for themselves very quickly in just adding restorative appointments. It will pay for itself very quickly. And Chris or Aaron, I think you guys want to jump in and talk about this, but basically those are the prices. I would, again, Ann and I don't get a couple percentage of that, too bad. But you may want to think about if buying 2, okay? You get a little break on the price. And I don't know if a NuSmile team, if someone buys one and calls like a week later and says, no, I want another one, do you honor that or no?
Absolutely.
Okay, good. If you order 4, actually, Chris will come to your house and deliver them. And if you order 5, Jordan will hand deliver them in costume. Thank you.
That is also true.
Yes. Okay.
Aaron, you got left
There's
out.
a little price break there on the SleeperOne. I'm personally a huge SleeperOne fan, but they both do the same thing. Okay. And then there's pricing on needles. If you do the onboarding like you're all supposed to, you will get still 1 free box of needles, correct?
That's correct.
You should not be doing this without doing the onboarding, please.
And then, speaking of money, you need to give your credit card to the people, Chris, Aaron, or Jordan. I really, like Josh said, we're really not salespeople. We're here to educate you on these devices. But I want you, while we're telling you how this is going to help your practice and help your patients, don't get, strike while the iron's hot. While you're thinking about it, like, send the email tomorrow and say, like, I'm ready to get one of these. Things I can tell you that'll help you make this transition is to be patient and to practice. Practice on your team members, your spouse, general anesthetic patients you're taking to the OR. Those are great patients to practice on, and be very patient. Like, you're going to bend needles. You might break a needle. You might get the pressure going up. You might not get somebody numb. You might hurt somebody. We all survived doing a buccal pit restoration with given a block on patients. So if we can do all of that, we can do all of this.
One quick, last quick piece of advice. Sorry, especially on a GA day, we're not used to looking at where the crestal bone is or where, how thick the cortical plate is. Next time you take out a tooth, look around in there, reflect the tissue back a little bit and see where that plate starts, see where, the base of it is, look at the thickness. It's thinner than you think it is. And one thing that I did a few times when I first started is after I took out the tooth, I just put the needle back into the same hole. I'm not causing any additional trauma to really see where I am. And that helped me in a 3D space understand where that needle is going.
So again, we encourage everybody to get in this Facebook group. That no one's throwing shade around in here. This is where you learn. People ask questions in here. Your butt will get thrown out if you're not being kind and positive in there. We want everyone in there to learn. I go on there just to learn things all the time. I'm like, oh, I never thought about doing it like that. Or, oh, that's a great idea or a great point. Lots of training is available. NuSmile travels are all around the country and outside of the country, training on materials and on obviously these devices. If you have a big enough group, or if you order enough devices, Chris will come to you and Jordan will come in a costume. These are just some of the events that these are some of the events we've all been involved with, teaching at military bases, residency programs, and continuing education courses. And this says some final thoughts. When you know the solution to all your problems and you just don't want to do them. This is how I live. I'm very stubborn with lots of things in my life.
Really?
And this is one thing I'm so glad I was not stubborn on. And I'm telling you, this is going to solve so many problems. This is a great marketing tool. This is compassionate to your patients. Your team members think you're cool because you're using new stuff. And it's going to benefit your practice immensely. And we just don't want you to overthink it. Like, that's where I think a lot of people get in trouble. They're just overthinking it. When you're in dental school learning how to give injections for the first time, there ain't no time to overthink it. Your professor's over you and the patient's there and you just got to do it. And I think sometimes we get in our own little bubble and we're just overthinking it. And I just encourage everyone to just breathe their way through it and lean into these people tonight that are on this call, and we will all help you. And don't reinvent the wheel. Back when these devices came here in 2023, we were having to figure it out for ourselves. We were having to troubleshoot it. Now we've got 2 years under our belt and we're here to help you. So don't reinvent the wheel. Don't sit there and suffer in silence. Like, call somebody, do something. And we really, I see Josh say this all the time. Josh, what do you tell people?
Make a video. So if you write us and try to write 17 paragraphs of, what the weather was like and what you had a problem with, it's hard for us to give you feedback. So ask parent permission and take a video. If you're struggling with one specific thing or all the things, take a video and send it to us. You send it to Chris or Jordan or Aaron, and then they will get it to us. And if we don't have the answer, we'll get you the answer. But we can diagnose, doing this long enough, it gives us, 30-second video, and we can see what's going on and we'll help you. It's usually positioning or, rotation of the needle, something like that, but send a video. We will help you.
9 times out of 10, a video shortens the learning curve like so quickly. And people have this aha moment like, oh my God, that's all it was. So these are the reasons that I want you to get it. Just remember, immediate action. Your anesthetic is going to be predictable, especially for hypoplastic teeth. There's no delay. Way less stress for everybody involved. Should not be having postoperative side effects once you get in your groove. Optimizing the appointments. And this is really going to, just launch the reputation of your practice. And I always say, if an old fart like myself can learn it, and here's my young fart who's a third-year dental student at MUSC doing it on his brother at Thanksgiving and getting his brother numb before we sit down for Thanksgiving dinner. I'm pretty sure everybody else on this call has the bandwidth and capacity to learn how to use these devices. I'm going to go through these. We'll get here to the end.
And if you want to talk about scanners, call me.
Yeah. If you want scanners, call Josh. These are the people... So many people that want to help you be successful in all areas of your dental practice to help your patients. And these are just a few of the rock stars that stand out for us. So please reach out. Chris, Aaron, Jordan, let's turn it over to you.
Yeah, so just wanted to remind everybody some upcoming restorative workshop classes with NuSmile. Nashville, February 21st. 1-day course, full day, hands-on lecture, everything with, BioFlex, SSCs, NeoPutty, NeoLiner, ZR, the whole 9 yards. And then Houston, November 15th, is our hands-on for tech. So we will have a full hands-on day. It's a Saturday as well. right at the airport, fly in, fly out at the hotel that's attached to the airport. It is going to be led by Dr. Solomon. So if you don't like him, I understand and you don't want to come, but he will be leading that. And again, it is a full hands-on opportunity with the devices, whether you're brand new user, super experienced, or still kind of on the fence. It's a great opportunity for you to get some hands-on learning and just take a really deep dive.
Honestly.
And also the scanners too.
Yeah.
And the scanner as well.
Our goal of this day is to go from you not knowing anything about the device, if that's the case, to feeling 100% comfortable. And thankfully, everyone that's teaching this have been using these devices for a long time. We will get you there. Come with your questions, write things down, ask me ahead of time. If you, at the end of it, want to talk about practice management stuff, if you want to talk about scanners, if you want to talk about restorative, I'm there to work. So please join us. I'm super excited about it. It's going to be all IO and scanning all day, and we will get you to expert level of understanding by the end of the day.
These are the QR codes for the upcoming tech webinars. So we have another for next month. We have another mastering mashup with Ann and Josh. And then we also have scanner webinar for digital impression scanning. And then we also have next month, we have a restorative webinar on bioceramics. So neo-putty, neo-liner.
Nice. Always doing something.
Is Paul teaching? I'm sorry, that's Patrick?
That is Patrick Ruck. Yes, sir.
Let me tell you, that is one of the best webinars I've watched in my entire career as a dentist. If you want to learn bioceramics, he's the guy you want to learn it.
This is everybody's contact info. Isabella's not on the call tonight, but you got Jordan and Aaron's contact info there. So please reach out to anybody if you guys do have questions. Again, any kind of CE questions, anything, product questions, and then obviously to order some of the devices.
Obviously.
Additional resources, just want to make everybody available. So if you are part of the DSO or a large group, we have dedicated team members, Preston and Eric, that handle that. If you are a resident or faculty, we have a dedicated team member that handles universities and other events. Her name is Nicole.
We just want to thank everybody for hanging in there with us tonight, and hope everyone has a great day tomorrow.
Awesome. We do have a bunch of questions.
I was just about to say, we are not done yet.
Yeah. Please stay on for the questions. They're good ones. First thing is, somebody did ask this, so I'll just reiterate. All of these webinars are recorded. We do post them onto the NuSmile website. So you can go back and watch this one. I know Ann mentioned earlier, you go back and watch one of the intros. All of them for the last 2 years are recorded and posted on the NuSmile website. So be sure to check that out if you have any other questions or anything. All right, let's dive into some questions. When you don't have adequate bone for IO and are using electronic delivery stage 1, are you still using the Epitech needles, traditional 30 gauge short needle? I'll answer that second part. The needle is 30 gauge. It's 9 millimeters. Both needles are 30 gauge, 9 millimeters. But I'll let Josh or Ann answer the first part.
I mean, it's maybe a personal answer for me, but I don't order any other needles but Epitech needles because I don't use traditional syringes. Also, the regular needles are a little bit more difficult to thread onto the devices. And it's right there. I've got the needle on. A normal needle is like 11 cents. It's 27 cents or 17 cents, 27 cents, a little bit more. So I'm just using it. Even if I'm just going into soft tissue, this needle is still it's still more comfortable than a normal needle because a normal needle is going to tear that tissue, and this is like got a scalpel blade on it.
My favorite party trick, if we were all in person, is as I'm talking, I learned this from Andrews. I will put a needle in my hand, and I could literally do it.
All right, next question. First part, can Dr. Solomon or Dr. Bynum show the stage 2 positioning for injecting on the lower left for a patient?
I mean, we
My
talk, but yeah.
My suggestion would be to go onto the Facebook group or have one of y'all send the videos that I made. Whoever's asking that question, I made videos. They've been posted a few different times
Oh, I forgot about that.
in the Facebook group showing the different positionings for the different quadrants. Because like talking through it is going to it'd probably be better if you had a visual. Not trying to blow you off, whoever's asking that question. I'm just trying to get
I forgot about those videos. Yeah, they're excellent. That's a good reason, another reason why to go through. I would just spend, if you have an hour or two, just scroll through that Facebook group.
Ain't nobody got an hour or two, Josh.
Well, if you have no life outside dentistry like I do. But spend the time going through that group, or if you have a question, just search the group, and most things have been asked already.
Yeah. You can always reach out to myself or Jordan or Aaron too. But we get a copy of all these questions, so we can absolutely reach out to you individually. The second part of their question was, on drive, my unit seems to drip anesthesia a little bit even after I am done injecting. Is this normal?
Normal. All that back pressure, especially after stage 2, when you bring that needle out, there's just a lot of pressure sometimes, and it's going to just want to come out the end of that needle. And also sometimes even on stage 1, when it's just, it's dripping so slowly, it'll do that as well. So having your assistance right there, having your dry vac in, like Josh suggested, those are all great, hacks to keep your patient from tasting all that.
Next question. I think this is directed to you, Dr. Solomon. How much of the carp did you use for NOPQ?
Good question. So general rule you can go with is a half a carp per quadrant. And let's add 2 questions together. Hi, Todd. I see this question about a number of patients feeling the rubber dams distal palatal corner of the E. So if you think about an orange, right? So the rind of the orange is the plate, and the inside of the orange fruit is the cancellous bone. Once you get through the rind and you're in the fruit of that, you're in the orange, you need to inject enough solution so that whole orange is filled. When the whole orange is filled, then that diffuses back out to the rind, aka the bone and soft tissue, and then you're going to have profound anesthetic 360 degrees around. When we say instantaneous local anesthetic, that is for the tooth. Okay, this is a great point, Todd. Thank you and whoever else asked this. Is we are dumping that local anesthetic right near the apex. Okay, it takes some time for that fluid to diffuse backwards, right? Normally, we're giving it in the vestibule, going through the plate into the bone to the apex. When you're giving that local anesthetic through the bone, you need to, number one, give enough volume so all the 360-degree anatomy there all gets numb, and you may need to wait a little bit, okay? I found that if that tissue is not numb right away, if I wait another 30 seconds, it's usually going to be numb. You also want to make sure that you're giving enough. So typically per quadrant, it's going to be, you find about a half part per quadrant. You're usually good for primary mixed dentition.
Yeah, I don't really go by that. I go by what I need to do in that quadrant and the age of the patient.
Yeah,
There's so many factors. If I'm doing a MODO, I'm using a quarter carpule. If I'm doing a hot tooth, maybe 3/4 carpule. Pulp and a crown, probably half a carpule. I mean, you got to read the room, just like you would with a traditional injection.
Right. The other thing, Todd, to think about is if you do want to give a little bit more bolus to the palatal tissue, let's say, you can just take that needle and go straight through the papilla and just walk it to almost so it's penetrating the contralateral side, and just step on the pedal and give that local there, and you'll see it walk around.
Awesome. Next question. When you are switching from stage 1 to stage 2, do you turn off stage 1 and then turn on the stage 2 button?
Button. Pedal? Pedal, yes. So yes, you're stepping on the inner part of the pedal for stage 1, and you're stepping on the outer U-shaped part of the pedal for stage 2.
Right. When you're transitioning from stage 1 to stage 2, you want to disengage the device. So stop delivering anesthetic solution. When you go to stage 2, once you make your injection, then you press the stage 2 pedal.
And just to clarify, so we're all on the same page, we're really talking about stage 1 is the papilla, stage 2 is the manual bone penetration, stage 3 is actually delivering. So just to clarify that,
Right.
so if you see things in writing, we're all on the same page.
All right. I know who's going to answer this one. So Dr. Solomon, this one's for you.
Oh, under 4.
Do you give Articaine to children ages 4 and under?
100%. So you can talk to Malamed about this one. Here's the thing. You have a DR in front of your name. The FDA give you general guidelines on drugs, but when it comes to the patient selection, that one is up to you unless there's a black box warning. When they did all the testing with Septicaine, the reason why that they didn't include children 4 and under or 3 and under was because there's not a lot of parents that want to have their kids injected with local anesthetic for a study. This device is used worldwide. It's been used worldwide for 15 years. And to this day, I have yet to see a study that says you cannot use Septicaine on child under 4. And everybody use it and you're going to be fine. Don't worry about it.
All right. Next question. Can you show the picture again that shows the D on the needle for stage 1? Just to see what that looks like again.
Can. Give me a moment right here.
Yeah, perfect.
Right
That's
there.
it. All right.
And the reason for that is when the D is facing out, the lumen is towards the bone, right? Because this isn't like a standard needle where it's just injecting on the edge. It's actually giving on the side of that lumen. So D is towards you, fluid is squirting out into the bone.
All right. Next question. On SOAN's cruise mode, after stage 1, should the pedal be pushed to stop and then restart, flush the pedal again for stage 2, or continue administering the anesthesia and redirect to angle according from stage 1 to stage 2?
I think the question is, are you just staying inside the skin? And no, you're not.
Yeah.
You're doing stage 1,
Right.
right under the papilla. Then you're going to come out. Some providers choose to come out and just re-angulate right away and step on the pedal, do stage 2 and then step on the pedal for stage 3. I don't. Someone alluded to it earlier about how the anesthetic will drip sometimes. After I do stage 1, I let my assistant rinse, and I also don't use a dry shield either. So I let the assistant rinse the patient's mouth out before I go back in and re-angulate, go into bone, and step on the outer part of the pedal for delivery of the IO. But it is 2 separate things that you're doing.
Yep.
Just
Exactly.
to be as clear as possible, stop your injection after you finish stage 1.
Yes.
1, 2, enter the bone at your proper depth and angulation. Start your
Step on the pedal.
injection at that
Correct.
point again.
Yep.
Correct.